Good afternoon and welcome to Westmead Hospital in Sydney. My name is Michael Bourke and I'm coming to you from Westmead and the University of Sydney, Australia. I'm going to talk to you about the invited article, GIE Perspectives, ESD. Will it always be a hyper-specialized skill? To put everything in context, it's undoubtedly very important that the skill of ESD is developed in the West. It was pioneered in Japan for the treatment of early gastric cancer, and it's grown from there. The advantage of ESD is that with a micro knife and careful endoscopic dissection, one can remove a tumour of almost any size throughout the gastrointestinal tract at the level of the muscularis propria, the deep layer, or even indeed intermuscular dissection, deliberately taking an internal muscular layer and achieve an en-bloc R0 excision. And this provides the opportunity for cure when we're talking about early neoplasms anywhere in the GI tract, be it esophagus, even pharynx, stomach, and colon. So why has it taken so long for ESD to come to the fore in the West? And probably the major reason is the lack of the easiest lesion to treat, early gastric cancer. So for example, in an excellent paper by Bronte Holt and colleagues and Linda Zhang, published a couple of years ago, they looked at the prevalence of early gastric cancer in the second largest state in Australia, Victoria, which at the time had a population of about 5.5 million. Over a 6-year period, there were only 1,220 gastric cancers reported to the Cancer Institute in Victoria, and it's likely that that's a reasonably accurate number. There might only have been a few missed because all cancer diagnoses are registered in Australia. And amongst those 1,200 cases over 6 years in a population of 5.5, or for argument's sake 6 million, about 20% Asian, so similar to American populations in major cities, there are only 20% early gastric cancers, or about 240 early gastric cancers, which works out at about 40 early gastric cancers per annum per 5.5 or 6 million population. So that number of gastric cancers, provided they all go for endoscopic treatment, would only really allow 2 people to maintain their skills in gastric ESD, or at least to learn gastric ESD, the easiest place to learn ESD. Of course, esophageal ESD is growing, and there's a clear role for the endoscopic management of early Barrett's cancer and T1B disease, early T1B disease, even high-risk T1B disease by ESD. And there's also a role in the rectum for ESD. So there are, of course, many other cases, but it's not like in the West we're replete with cases that we can learn and train on. And I think animal training is a very poor substitute. So that's probably the reason why the uptake's been so slow. And of course, in the West, the tumour board discussions are dominated by surgeons. Advanced endoscopists often don't go. And so patients miss out on the opportunity to be treated in the least invasive way. This paradigm is changing for several reasons, particularly because increasingly patients want the treatment that they deserve, and that's the least invasive, comparably effective treatment. So for example, in the esophagus, patients do not want esophagectomy. The morbidity is high. Mortality approaches 20% for patients in their 80s, 30-day mortality. And the same in the rectum. Patients don't want stomas. Increasingly, patients are driving these decisions and seeking other ways that they can be treated for early neoplasia or locally advanced neoplasia without the need for organ excision and indeed organ preservation. Any patient who undergoes esophagectomy, I'm sure many of you would have seen them in your office over the years. They're generally often fairly miserable in follow-up. They have an anastomosis in the chest, a lot of regurgitation at night, lose a lot of weight, and so on. So quality of life is a critical issue. So that begs the question, well, what about ESD in the colon? So in the West, we have a high prevalence of large laterally spreading adenomas, which can be managed effectively by EMR. But in the case of low-risk submucosal invasive cancer, these lesions would not be cured on technical grounds if they were removed piecemeal. So if cancer is suspected, then one should opt for ESD. And we do a lot of rectal ESD. We published a paper showing that the risk for the risk of cancer in the rectum is 2.5 times that of the rest of the colon for large laterally spreading lesions. And so if the lesion's not flat and we can't be sure there's no invasive disease, we'll always do ESD. But ESD in the rectum is a hard place to learn because there's a lot of blood vessels, a lot of bleeding, and so on. It's safe, but it's technically difficult. In fact, esophageal ESD, I believe, is much easier. So what about the rest of the colon? Well, you may be familiar with the paper published by Jacques et al. That's in the Annals of Internal Medicine in January or February, and we wrote the editorial for that. But finally, in a randomized trial of 360 laterally spreading lesions, the EMR versus ESD, the rate of surgery between the two groups was the same, 11 versus 8, EMR versus ESD, because there were several complications from the ESD arm. And colonic ESD is difficult. It's not difficult for someone who's experienced at ESD. We do quite a bit of it, but we only do it where we suspect cancer or we have proven cancer and it's justified, because it takes 4 times as long and it's resource intensive. And in these days where resources are constrained and the work that we have to do, everyone's work is multiplying, and we need to make sure that we maximize the output from the endoscopy unit whilst not compromising outcomes or adding burdensome expense, waste, or opportunity costs. So always we must tailor the therapy to the pathology. So in summary, undoubtedly there is a critical role for ESD within Western endoscopy practice, but its role is niche and specifically for early gastric cancer, also submucosal tumours and so forth. I haven't got into that. Esophageal tumours that are larger than 15 to 20 millimetre that require en-bloc excision, so particularly Barrett's esophagus, but we also do a lot of resection for squamous cancer, early squamous cancer, and then finally for large rectal lesions where overt or covert submucosal invasive cancer is suspected. Its role in the colon, I think, if we embrace evidence, will remain limited. So thank you very much for listening to me.